Good morning, everyone. My name is Bandit Tantiwongkosi. I am from University of Texas, San Antonio. It is my pleasure to be a co-moderator with Dr. Karen Mueller from University of Louisville and Northern Children's Hospital. We would like to welcome all of us to the first virtual meeting of ASHNR 2020. This session is dedicated for core curriculum of emergency medicine. There are 6 fantastic speakers. The first speaker is Dr. Sarah Strauss. Dr. Strauss is an assistant professor of radiology at Weill Cornell Medical Center in New York. She will talk about skull-base and temporal bone fractures. The second speaker is Dr. ASHNR Sama. Dr. Sama is an assistant professor of radiology at Monroe Carell Jr. Children's Hospital, Vanderbilt University Medical Center in Nashville, Tennessee. She will talk about orbital emergencies. And the third speaker is Dr. Blair Wenneker. Dr. Wenneker is an assistant professor of radiology, ophthalmology, and neurosurgery at University of Arizona in Tucson. And he will talk about maxillofacial fractures and dislocation.
Hello, my name is Sarah Strauss, and today I will be speaking with you about skull base and temporal bone fractures. I would like to thank Dr. Schmolfus and the ASHNR for the invitation. Today, when we speak about skull base and temporal bone fractures, we'll begin by thinking about skull base and temporal bone anatomy. We'll then take a segmental approach to skull base fractures, looking at the anterior, middle, and posterior skull base, and we'll think about associated complications. The skull base is comprised of 5 bones, 2 of which are paired and 3 of which are unpaired. The 2 paired bones are the frontal and temporal bones, and the 3 unpaired bones are the sphenoid, the ethmoid, and the occipital bones. And the petrous portion of the temporal bone and the greater wings of the sphenoid are important for identifying structures, so it is useful to familiarize oneself with the nooks and crannies of these 2 bones. Here is a graphical depiction of skull base osseous anatomy. The anterior skull base is comprised of the frontal bone and extends to include the planum sphenoidale, and the posterior margin is formed by the anterior clinoid process. The central skull base extends from the lesser wing of the sphenoid to the petrous ridge and transmits cranial nerves 2 through 6. The posterior skull base extends from the dorsum sella to the occiput, and it transmits cranial nerves 9 through 12. Taking a closer look at the anterior cranial fossa, this is a graphic depiction of the anterior skull base. You can see cranial nerve 1 resting upon the cribriform plate. The posterior margin of the anterior cranial fossa is the anterior clinoid process of the lesser wing of sphenoid. Here's a graphical depiction of the central skull base, and so you can see that it extends from the anterior clinoid process to the dorsum sella and the petrous ridge, and it transmits cranial nerves 2, 3, 4, 6, and 5. And finally, the posterior skull base is shown here. It extends from the dorsum sella to the occiput and transmits several cranial nerves as shown here. Skull base and temporal bone fractures occur in 7 to 16% of non-penetrating head injuries and usually result from high-velocity trauma. Only 10% of cases are due to penetrating trauma. Importantly, there are several associated injuries, including CSF leak, cranial nerve injury, or vascular injury. In imaging a patient presenting with trauma and potential skull base fracture, we usually begin with a non-contrast head CT to evaluate the intracranial compartment. Bone algorithm, multi-detector CT with thin cuts and multiplanar reconstructed images are useful to evaluate for the more subtle fractures of the skull base. Vascular imaging can be performed in the setting of suspected vascular injury, and MR is useful for further characterizing intracranial injury or when a traumatic encephalocele is suspected. Anterior skull base fracture or frontal basal injuries represent 3 to 5% of craniomaxillofacial fractures. The frontal component of that expression includes the upper third of the frontal compartment, and basal refers to the anterior skull base. That includes the cribriform plate, the ethmoid roots, and planum sphenoidale. And several classification schemes exist. The importance in choosing your description and classification is in thinking about how that reflects the associated complications. Here's an example of an anterior skull-base fracture classification scheme, which divides fractures into types 1 through 3, depending on whether there's a central, lateral, or combined involvement. Central refers to involvement of the cribriform plate, ethmoid bone, and planum sphenoidale, and lateral refers to involvement of the orbit and optic canal. Fractures can be further characterized as involving frontal or basal components, and then they can be pure or impure depending on whether there are associated other maxillofacial injuries. And importantly, a CSF leak and intracranial complication are more common with impure fractures in type 2 and 3 fractures. Piccarelli classification focuses on involvement of the frontal sinus. It's known that when a fracture extends through the posterior wall of the frontal sinus, the patient is at increased risk for cerebrospinal fluid leak and ultimately mucocele formation, and may require specific surgical management, potentially cranialization. And so a type A fracture shown in the schematic involves only the anterior wall of the frontal sinus. A type B involves the anterior and posterior walls of the frontal sinus, and a type C is a frontobasal fracture without frontal sinus involvement. Here's an example of an anterior skull base fracture in a 16-year-old male who fell from a fire escape in his apartment building at a party. You can see the frontal fracture line extending in a craniocaudal direction inferiorly through the anterior and posterior margins of the frontal sinus. So this would be a Piccarelli B. There's involvement of the anterior skull base, so there's a basal component extending through the ethmoid to the planum sphenoidale. Another important thing to note in this patient is potential vascular involvement. So you can see that the fracture line courses in close proximity to the anterior ethmoidal artery as well as the carotid canal as it extends towards the central skull base. This is a patient in whom you would want to suggest CT angiogram to rule out carotid injuries such as pseudoaneurysm formation. Here's another example of anterior skull base fracture. This was a 30-year-old female who was an unrestrained backseat passenger involved in a motor vehicle collision. And so we can think about how we might classify this fracture. There's involvement of the anterior and posterior margins of the frontal sinus, so it would be a Piccarelli B. You can see that there's both central and lateral involvement with comminution. So this would be a 3FB. And this patient is at risk for CSF leak as well as intracranial injury. Complications associated with anterior skull-base trauma are shown here, some of which we've already alluded to in the previous slides. That would include CSF leak, meningoencephalocele, cranial nerve 1 injury, intraorbital injury, and mucocele formation. CSF leak can occur when there's both osseous and dural defect and is seen in up to 30% of skull-base fractures. Although most will occur within the first 48 hours, up to 5% may present in a delayed fashion months or even years after the trauma. And the good news is that the majority will heal spontaneously. If the leak does not resolve within up to 7 days, CSF diversion might be necessary. And if there's persistent leak beyond 10 days, surgical repair will be necessary because, as you can see, the risk for meningitis increases over time. This is a patient who had multiple maxillofacial fractures, which were repaired, who presented in a delayed fashion with CSF rhinorrhea. You can see that there's a defect along the fovea ethmoidalis and planum sphenoidale with contiguous soft tissue extension. MR performed for procedure planning demonstrates encephalomalacic tissue extending through the skull base defect, and there is CSF intensity fluid within the maxillary sinus. This patient underwent endoscopic repair and performed quite well afterwards. Olfactory nerve injury is a risk when there's involvement of the anterior skull base in the setting of trauma. This is a 42-year-old female with history of head trauma who presented a year and a half later with anosmia and alteration in taste, which actually resulted in weight loss. On imaging, you can see that there's encephalomalacia in the right greater than left gyrus recti, as well as volume loss and flattening of the right greater than left olfactory bulbs. Moving on, let's discuss the middle cranial fossa fractures, including the central skull base, the sella parasellar region and cavernous sinus, as well as the lateral skull base, which refers to the temporal bone. Middle cranial fossa or central fractures occur more commonly as posterior extension of frontobasal fractures as compared to anterior extension of clivus or posterior skull base fractures, and most will involve the sphenoid sinus. Central skull base fractures may occur in an oblique or transverse pattern. Oblique fractures occur from a frontal impact, posterior expansion of a type 2 or 3 frontal basal fracture, and have increased risk of CSF leak, whereas a transverse pattern fracture will occur from a lateral skull or zygoma impact, and this has increased risk of cranial nerve injury or vascular injury. Complications associated with central skull-base trauma include ICA injury if the fracture lines extend through the superior orbital fissure, the anterior clinoid processes, or the cavernous sinus. The patient is at risk for cranial nerve pathology. If there's extension through the orbital apex, the patient may experience visual loss. And if there's involvement of the sella due to the position of the optic chiasm, the patient may have a bitemporal hemianopsia. ICA injury is also possible in the setting of central skull base fracture. ICA injury can include transection, dissection, pseudoaneurysm formation, or carotid cavernous fistula formation. Here's an example of a 55-year-old female who had remote history of trauma, and she presented with worsening right eye proptosis and partial right third and sixth palsy. And here you can see in a right internal carotid artery injection, there is direct flow from the right ICA into the cavernous sinus through a CC fistula. There's retrograde venous outflow into the deep venous system via the basal veins of Rosenthal, the vein of Galen, and the straight sinus, as well as superiorly into the superior sagittal sinus. And what you also may have noted was that there's really no flow within the ICA beyond the level of the fistula. CC fistula may occur in an acute or delayed fashion, and it represents a single hole in the cavernous sinus which shunts into the cavernous, single hole in the cavernous ICA which shunts into the cavernous sinus. And DSA is important for both diagnosis and treatment. Moving on, let's talk about the posterior lateral middle skull base. We'll speak about temporal bone fractures. The majority of temporal bone fractures are unilateral. They are often associated with other injuries that require acute management, and complications are multiple. Patients may have facial nerve paresis or paralysis. There may be hearing loss or CSF leak. Surgery is indicated if there's persistent conductive hearing loss, TM perforation, or cerebrospinal fluid leak, if there's severe facial nerve injury, if there's severe comminutive fracture, or if there's EAC fracture resulting in stenosis. Clinical clues to temporal bone fractures include the battle sign, which is postauricular ecchymosis or hemotympanum. And on head CT, you may see mastoid opacification or epidural blood or pneumocephalus adjacent to the temporal bone, which will prompt you to suggest that dedicated imaging of the temporal bone be performed to look for a more subtle fracture. Air within the temporal mandibular joint is also suggestive of temporal bone fracture in the setting of head trauma. Historically, classification of temporal bone fractures were longitudinal versus transverse. Longitudinal fractures being parallel to the long axis of the petrous portion of the temporal bone, more common and more likely to be associated with conductive hearing loss. Transverse fractures are perpendicular to the long axis of the petrous portion of the temporal bone. These are less common and more likely to result in sensorineural hearing loss. However, cadaveric experiments have shown that many fractures are actually mixed or oblique in pattern. And more importantly, the fracture direction did not have great correlation with clinical outcomes. And so now the more common practice is to describe fractures as otocapsule sparing versus violating. Otocapsule violating meaning that there's involvement of the cochlea, vestibule, or semicircular canals. If a fracture is otocapsule violating, there's more likely to be sensorineural hearing loss, cranial nerve 7 injury, or CSF leak. Here's a suggested checklist for T-bone fractures. So you want to think about whether or not it's otocapsule sparing or violating. You want to describe the location and direction of the fracture, the status of the ossicles, the facial nerve canal, whether or not it is involved, the status of the tegmen tympani and tegmen mastoidium, and then comment on the adjacent vascular structures. Here's an example of an otocapsule sparing fracture in a 16-year-old who fell from his bike without wearing a helmet. You can see that there's a longitudinal fracture that extends towards the middle ear cleft. It's otocapsule sparing, and there is incutomalleolar separation or subluxation, as you can see here. Ossicular injury occurs in longitudinal fractures more often than transverse type fractures, and the incus is most commonly affected because of its large size and relatively weaker ligamentous support. Description of ossicular injury can be subluxation, frank dislocation, or fracture. Here's an example of an otic capsule violating fracture in a 40-year-old male who had facial paralysis and hearing loss. You can see that this is an otic capsule violating fracture. There's extension through the vestibule towards the facial nerve canal. There's pneumolabyrinth, which raises concern for fistula. I also want to draw your attention to two lucencies that are not fractures. Here you can see a lucency extending from the internal auditory canal towards the vestibule, and this is not a fracture. This is the singular canal which transmits the posterior ampullary nerve, a branch of the inferior vestibular nerve. Similarly, here we can see an anterior convex lucency which meets the fracture line but does not actually represent a fracture. And this is the petromastoid canal. It is not a fracture. And so it's useful to familiarize oneself with the canals and fissures of the temporal bone so as not to mistake a normal structure for a fracture. And when in doubt, use symmetry to help you. Here's an example of an otic capsule violating fracture. This was a 2-year-old child who had a bookcase fall on his head, sustaining a TBI. You can see that there are multiple fractures extending into the greater wing of sphenoid. There's an otic capsule violating component with air within the vestibule, as well as the lateral semicircular canal. This patient ended up with long-term complications and presented 3 years later with persistent sensorineural hearing loss. And here you can see that there's high-density material in the expected location of the lateral semicircular canal, and this patient had labyrinthitis ossificans due to the presence of blood products within the membranous labyrinth. If this were present within the cochlea, it would make cochlear implantation very difficult for the surgeon. Finally, let's talk about posterior skull-base fractures. Posterior skull-base fractures occur as a result of direct blow to the occiput. It can involve the occipital bone and the petrous portion of the temporal bone. They can be longitudinal or transverse and tow several complications, including arterial injury, epidural hematoma, which may be venous thrombosis, cranial nerve injury, and if there's involvement of the clivus, cranial nerve 6 palsy. Here's an example of a posterior skull-base fracture. This patient had multiple skull-base fractures, but I want to focus on the involvement here of the left occipital condyle and clivus. This is a patient who might begin to worry about cranial nerve 6 involvement, but also on CT angiogram, you can see that there is extension of the basilar artery through the traumatic defect within the clivus, and DSA nicely demonstrates the resultant dissection. So patients with posterior skull-base fracture are at risk for arterial complications of the vertebral-basilar system. Here's another example of a patient with posterior skull-base fracture. This was a 6-year-old who fell from a folding table at a laundromat. You can see that there's fracture through the occipital bulb as well as the jugular fossa, and you can see that there is air along the sigmoid plate on the left. Post-contrast imaging performed to evaluate venous structures shows that there's a filling defect adjacent to that locule of air within the sigmoid plate along the course of the distal transverse and sigmoid sinuses, as well as lack of opacification of the jugular bulb. And so this patient had venous thrombosis as a consequence of posterior skull-base fracture. Imaging performed several months later shows that there is resolution of the previously seen filling defect, and the patient did quite well. In summary, in speaking about skull base and temporal bone fractures, it's useful to think about skull base anatomy in order to lead your thinking about associated vascular or cranial nerve injury. In describing fractures, consider classification use that relates to clinical outcomes. And finally, beware of pseudofractures. And when in doubt, use symmetry to help clarify. I thank you for your attention.
Hi. My name is Asha Sarma, and I'm a pediatric neuroradiologist at Vanderbilt. The topic of this presentation is an indication-based approach to imaging of orbital emergencies. The goal of this presentation is for the viewer to be able to generate an imaging differential diagnosis and recognize salient findings for emergent orbital conditions. Although real life is often more complicated, the disorders discussed in this presentation will be organized based on primary indications from 4 major categories: trauma, acute vision loss with or without pain, swelling, and proptosis. First, we'll discuss patients presenting with a given indication of trauma. Orbital fractures are included elsewhere in the program, so here we'll focus on soft tissue injury of the globe and the retrobulbar structures. Anterior segment structures of the eye include the cornea, the anterior chamber which contains aqueous humor, the lens, the ciliary body, and the zonular fibers which attach the lens to the ciliary body. Traumatic hyphema is hemorrhage in the aqueous humor, usually caused by corneal laceration. Traumatic cataract is caused by abnormal osmotic hydration of the lens. In this case, where the patient's eye was injured by a firework, CT shows hyperattenuation of the anterior chamber due to hyphema and low attenuation of the lens due to traumatic cataract. Lens dislocation injuries occur along a spectrum from subluxation at the mild end to extrusion at the severe end. Lens subluxation results from partial tearing of the zonular fibers which attach the lens to the ciliary body. These images from the literature illustrate that lens dislocation from complete disruption of the zonular fibers may be anterior or posterior. Anterior dislocation may be evidenced by differing depth of the anterior chambers between the two eyes, and although it may be subtle, it is important to recognize because it may result in acute closed-angle glaucoma. With dislocation of the lens and open globe injury, the lens may be completely extruded, as in this case where the left lens was not identified at imaging or surgery. Structures of the posterior segment include the vitreous body, and from innermost to outermost, the retina, choroid, and sclera. Traumatic posterior segment hemorrhage into the vitreous body manifests as heterogeneous hyperattenuation of the posterior segment. This is an example of vitreous hemorrhage and intraocular gas due to penetrating injury. Traumatic retinal and choroidal detachment can also be associated with hemorrhage. A special category of traumatic hemorrhage is retinal hemorrhage, which is associated with abuse of head trauma in pediatric patients. This results from shearing of the vitreous from the retina due to a shaking mechanism. Gradient echo MR image in an infant with abusive head trauma shows foci of susceptibility corresponding to retinal hemorrhages which were seen on ophthalmoscopic examination. The term open globe injury refers to full-thickness tearing of the cornea or the sclera or both. Open globe injury can result from blunt or penetrating trauma. CT signs include globe deformity or contour irregularity, which may be subtle, decrease or increase anterior chamber depth, and globe volume loss. In this example, there is a classic flat tire sign, so called due to volume loss and flattened shape of the globe. Extraocular or retrobulbar soft tissue injuries may involve the intraconal and extraconal spaces, the optic nerve sheath complex, or the extraocular muscles. We will be discussing orbital compartment syndrome and traumatic optic neuropathy, which are two critical complications of retrobulbar injury. Orbital compartment syndrome is a vision-threatening complication of increased interorbital pressure from various causes that can lead to impaired perfusion and ischemia of the optic nerve. This patient was injured in a motor vehicle collision, and extraconal collections caused proptosis with stretching of the optic nerve and posterior globe tenting. These are findings that have been associated with orbital compartment syndrome, though it is ultimately a clinical diagnosis. The triangular shape of the globe in orbital compartment syndrome has been referred to as the guitar pick sign. The treatment is emergent orbital decompression. Multiple ocular and retrobulbar injuries are seen in this patient who had marked proptosis. Diffusion-weighted MRI shows low diffusivity of the optic nerve consistent with ischemic injury from traumatic optic neuropathy. Traumatic optic neuropathy is most often due to indirect injury related to shearing force on the intercanalicular segment of the optic nerve. Clinically, this presents with acute vision loss. Imaging may be helpful to identify optic canal fractures, collections within the optic canal or along the optic nerve sheath, as well as foreign bodies. Foreign bodies may be found anywhere in the orbit, including within the globe. CT is the most sensitive imaging modality. Foreign bodies may be classified as organic, non-metallic, for instance plastic or glass, or metallic. Organic foreign bodies may be the most difficult to detect at imaging, however are important to identify due to increased risk of infection, especially if they are intraocular. Though this is not exactly an eye test compared to some small foreign bodies, this example illustrates how organic foreign bodies such as those made of wood may be mistaken for air. In soft tissue and bone windows, the wooden stick that has impaled the orbit appears similar to air. An intermediate window somewhere between a bone and lung window raises conspicuity of the foreign body. Next, we'll address emergent conditions presenting with acute vision loss, including ocular detachments and papilledema, which may be painless, and optic neuritis and ocular infection or inflammation, which are typically painful. Ocular detachments result from accumulation of fluid between the layers lining the interior surface of the globe. Typical presenting symptoms include the appearance of floaters, decreased acuity, and sometimes pain. Here we'll focus on retinal and choroidal detachment. There are numerous non-traumatic and traumatic causes of retinal detachment, with one of the more common non-traumatic causes being diabetic retinopathy. Abnormal fluid collections may result from breakdown of the blood-retina barrier, abnormal traction on the retina, or retinal tearing. On CT and MRI, there is a characteristic V-shaped or gull-wing configuration of retinal detachment. Anteriorly, the detachment is limited at the ora serrata, and posteriorly, the detachment extends to the optic disc. Choroidal detachment is caused by decreased intraocular pressure, most often due to surgery or trauma, and various other underlying causes. The shape of the collections differs from those in retinal detachment. Anteriorly, they extend past the ora serrata to the ciliary body, and posteriorly they are confined by the insertion of the vortex veins. Therefore, they spare the posterior third of the globe. One of the most important roles of the radiologist in imaging ocular detachments is to identify underlying conditions, as in these cases of retinoblastoma and melanoma, with associated retinal detachment. Next, we'll discuss imaging of acute painless vision loss due to papilledema. Papilledema is swelling of the optic nerve due to increased intracranial pressure transmitted to the optic nerve sheath along the subarachnoid space. Characteristic MRI findings include increased width of the optic nerve sheath, flattening of the posterior aspect of the globe, and elevation of the optic papilla. The radiologist is often asked to evaluate for causes of increased intracranial pressure. Now we will transition to discuss conditions that tend to present with visual loss and eye pain, such as optic neuritis. Optic neuritis is inflammatory demyelination of the optic nerve that can be caused by various disorders. As seen in this example of a child with anti-MOG antibody-related disease, imaging findings include enlargement, edema, and abnormal enhancement of the nerves. Optic neuritis is primarily a clinical diagnosis, and the major roles of MRI are to provide confirmation of the diagnosis and evaluate patterns of disease in the optic apparatus, brain, and spine, which can help with a specific diagnosis. Notably, the longitudinal extent of optic nerve involvement has been shown to correlate with the degree of visual impairment and the prognosis. Demyelinating disorders can show differing characteristic patterns of optic nerve involvement. For example, multiple sclerosis tends to present with unilateral retrobulbar nerve inflammation. Anti-MOG demyelination presents with bilateral longitudinally extensive lesions, and anti-aquaporin 4 positive NMO tends to present with bilateral chiasmatic involvement. Next, we'll be discussing painful visual loss due to ocular infection known as endophthalmitis. This is bacterial or fungal infection of the aqueous and vitreous humor. Imaging findings include thickening and enhancement of the ocular wall and periocular inflammation. MRI may show abnormal signal within the globe on FLAIR and DWI. Non-infectious inflammatory disorders can also cause inflammation and hyperenhancement of the globe and surrounding tissues, as in this companion case of a teenager with Vogt-Koyanagi-Harada syndrome, which is a rare autoinflammatory condition with multi-organ involvement. Imaging can be especially helpful in inflammatory disease and infection that primarily involves the posterior structures that are inaccessible to ophthalmologic examination. Next, we'll consider infectious conditions that tend to present with eye swelling, including periorbital and orbital cellulitis, invasive fungal infection involving the orbit, and dacryocystitis. Suspected periorbital or orbital infection is among the more common indications for imaging the orbits, especially in pediatric patients. The key anatomic structure separating the preseptal and postseptal spaces is the orbital septum. On axial images, this can be imagined as a line connecting the lateral orbital rim and the anterior aspect of the globe. Preseptal cellulitis is a complication of superficial facial infection or trauma. Symptoms tend to be mild. For example, this child presented with painless eye swelling and no systemic symptoms. On CT, inflammatory changes are strictly confined to the tissues anterior to the orbital septum. Preseptal cellulitis is treated with outpatient oral antibiotics. Postseptal cellulitis is most often a complication of sinus infection. Clinical symptoms are more severe than in preseptal cellulitis. In this child, there is subtle fat stranding in the medial and inferior extraconal space adjacent to the inflamed ethmoid and maxillary sinuses and swelling of the medial and inferior rectus. However, there is no evidence of abscess. Postseptal cellulitis is often treated with IV antibiotics on an inpatient basis. Subperiosteal abscess is the most common complication of sinogenic orbital infection. Ethmoid disease tends to cause medial subperiosteal abscess, which is more common than superior subperiosteal abscess, which is caused by frontal sinusitis. Management of larger subperiosteal abscesses includes surgery and IV antibiotics. This case of a child with orbital infection and sinusitis shows fat stranding within the intraconal space of the right orbit. Compared to the normal left superior ophthalmic vein, the right superior ophthalmic vein is enlarged and hypoattenuating due to thrombus. This child also had cavernous sinus thrombosis, as evidenced by a hypoattenuating filling defect in the cavernous sinus. Venous thrombosis is a rare complication of orbital infection. Treatment generally includes management of the underlying infection as well as anticoagulation. Dacryeus cystitis is inflammation and swelling of the lacrimal sac and is usually a complication of congenital obstruction of the nasolacrimal duct. Patients present with infectious signs centered in the medial canthal region, as in this patient. Imaging shows enlargement and peripheral hyperenhancement of the lacrimal sac with swelling of the surrounding tissues. Patients with acute Dacryeus cystitis must be treated promptly due to risk of orbital complications and sepsis. Treatment consists of antibiotics and sometimes surgical decompression. I'm going to try that one more time. Dacryeus cystitis is inflammation and swelling of the lacrimal sac and is usually a complication of congenital obstruction of the nasolacrimal duct. Patients present with infectious signs centered in the medial canthal region, as in this patient. Imaging shows enlargement and peripheral hyperenhancement of the lacrimal sac with swelling of the surrounding tissues. Patients with acute Dacryeus cystitis must be treated promptly due to risk of orbital complications and sepsis. Treatment consists of antibiotics and sometimes surgical decompression. One of the most morbid conditions affecting the orbit is angioinvasive fungal infection, which is usually a complication of fungal sinusitis in immunocompromised patients. Predisposing conditions include uncontrolled diabetes or neutropenia. Fungal infection tends to progress rapidly over days or weeks. This patient with poorly controlled diabetes initially presented with sinusitis with concerning features on CT, including erosion of the posterior wall of the maxillary sinus, inflammatory changes in the perisinus fat pads, and subtle inflammation in the adjacent extraconal space and overlying soft tissue. MRI is needed to evaluate the full extent of orbital infection, identify any areas of ischemic non-enhancing tissue that require surgical debridement, and characterize any intracranial involvement. In this example, the patient developed extensive intraconal and extraconal inflammation, as well as abnormal enhancing tissue extending to the cavernous sinus via the orbital apex. Ultimately, the orbit was filled with abnormal enhancing tissue with signs of orbital compartment syndrome. Fortunately, the patient survived but lost vision in the affected eye, even in spite of aggressive therapy. The last major emergent indication for orbital imaging that we'll discuss is proptosis. This may be caused by masses, inflammatory disorders, and vascular pathologies. Vascular anomalies and aggressive neoplasms are typically the only intraorbital mass lesions that are sufficiently rapidly growing to cause acute proptosis. This may cause injury to the optic nerve due to stretching. In this example, this infant developed sudden onset proptosis due to hemorrhage into a retrobulbar lymphatic malformation. The patient underwent emergent orbital decompression with evacuation of the hematoma. Idiopathic orbital inflammatory syndrome, or IOIS, may also present with various symptoms, including proptosis and painful ophthalmoplegia. This entity has previously been called pseudotumor due to its sometimes mass-like appearance. IOIS is a heterogeneous disorder of unknown cause with variable manifestations. These MRI images show enlargement and hyperenhancement of the right lacrimal gland and multiple extraocular muscles, the intraconal fat, and the optic nerve sheath. The coronal CT image shows soft tissue attenuation replacing fat at the orbital apex. IgG4-related disease of the orbit is a more recently characterized entity that may involve multiple organ systems. It can be distinguished from IOIS by serum testing or biopsy. Approximately 25 to 50% of patients previously thought to have IOIS may instead actually have IgG-related disease. Like IOIS, there are protein manifestations that vary according to the sites of involvement. The most common pattern is bilateral lacrimal gland inflammation. IOIS and IgG4 disease overlap considerably, but they may differ from one another in a few ways. Importantly, IgG4 disease tends to be more indolent in onset and is therefore relatively unlikely to present with pain in an emergent situation. The pattern of myositis also differs between the two disorders. IgG4-related disease has a predilection for the lateral rectus and tends to spare the myotendinous junction. Last, we'll discuss carotid cavernous fistula, an emergent vascular condition that causes proptosis. Carotid cavernous fistulae are abnormal communications between the carotid arterial system and the cavernous sinus. Carotid cavernous fistulae may be spontaneous or result from trauma and may be direct or indirect. Symptoms include proptosis, painful ophthalmoplegia, chemosis, and visual loss. In a patient with previous trauma, this angiographic image obtained during right ICA injection shows abnormal early opacification of the cavernous sinus. This patient presented with fractures involving the right carotid canal. A few weeks later, the patient developed worsening proptosis and chemosis. CTA showed marked proptosis with stretching of the optic nerve and tenting of the globe, concerning for increased intraorbital pressure with engorgement and hyperenhancement of the extraocular muscles, and enlargement of the superior ophthalmic vein. Carotid cavernous fistula that was not visible at the time of initial trauma is evidenced by enlargement and arterial phase enhancement of the right cavernous sinus. The fistula was subsequently embolized. In conclusion, the spectrum of orbital emergencies may present with various symptoms that may overlap. However, it is useful to develop differential diagnoses based on commonly given indications for imaging in the emergent setting, including trauma, visual loss, swelling, and proptosis. Thank you for your attention, and thank you to Dr. Schmalfuss and the ASHNR for the opportunity to speak. I would also like to extend my sincere thanks to my colleagues, Dr. Pruthi, Olino, Tomlinson, and Groth. Here are my references. Have a wonderful time at the virtual meeting, and thanks for meeting with me in the virtual space.
Hi, my name is Blair Winiger, and I'm going to be discussing maxillofacial fractures and dislocations. I have no financial disclosures. I would like to thank Dr. Schmalfuss and the program committee for allowing me to speak today. So in this lecture, I'm going to first briefly describe the facial buttress system and how it influences surgical management of facial fractures. Next, I'm going to go through the gamut of complex facial skeletal traumatic injuries and some of the potential complications in each of these fracture patterns. And finally, I'm going to discuss some of the newer imaging innovations which our surgical colleagues are using in treatment of these patients. So first off, the facial skeleton is a complex anatomic structure formed by 14 facial bones and portions of 5 cranial bones. And it houses the orbits, nasal cavity, paranasal sinuses, and it protects our ability to see, breathe, smell, eat. And so when describing facial fractures, it's better to describe the anatomic subunits that are involved, such as the medial orbital wall, instead of trying to describe each individual bone which is fractured. So the facial buttress concept is a concept which divides the face into transversely oriented and vertically oriented struts or buttresses, similar to the walls of a building. And at the anterior margin of these struts, we have thickening of the bone, which allows the facial reconstructive surgeons to reapproximate these bones and apply rigid plate and screw fixation to treat facial fractures. So these are the facial fracture patterns I'm going to discuss. So first, we're going to talk about Lefort fractures, which were first described in the early 1900s by the French surgeon René Lefort. And these are high-impact trauma fractures which create some dissociation between the face and the remainder of the skull base and calvarium. And so when Lefort described them, he described them as three distinct types, which were bilateral symmetric. But as you probably know, in clinical practice, we can see these in concert. So you can see a Lefort 2 and a Lefort 3 in the same patient. They can be unilateral, so you can have a hemi-Lefort 2 on just one side, or you can see them in mixed components, like a Lefort 2 on the right side and a Lefort 3 on the left side. So the commonality of these fractures is that they all have fractures through the pterygoid plates, and the pterygoid plates are actually the junction of the face with the skull base. So the Lefort 1 fracture is a fracture that goes transversely right above the palate and dissociates the palate from the remainder of the face. The Lefort 2 fracture is a pyramid-shaped fracture which extends from the nasal bridge infralaterally on both sides through the orbits and maxillary sinuses and creates a pyramid-shaped bone of the face which is dissociated from the remainder of the face and skull base. And lastly, the Lefort 3 fracture is a total craniofacial dissociation where the entire face is dissociated, and this fracture extends through the orbits and laterally through the zygomatic arches. So these are axial and coronal images showing a patient with a complex facial trauma which has components of all three Lefort fractures. The green arrows are showing the fractures through the pterygoid plates which are necessary for a Lefort fracture to exist. The red arrows are showing that transversely oriented fracture which decoupled the hard palate from the remainder of the face. The blue arrows are showing that the pyramid-shaped Lefort 2 fracture, and the yellow arrows, the fractures necessary for a Lefort 3, which extend through the lateral orbital walls and zygomatic arches. So the Lefort fractures have unique features, and so if you look for these specific features, you can kind of help guide you in describing these fractures. The type 1s will extend through the lateral margins of the nasal fossa and inferior nasal septum and typically spare the orbits, whereas the type 2 will involve the inferior orbital rim, and the type 3 will go laterally through the lateral orbital rim and walls and zygomatic arches. So next is the zygomaticomaxillary complex fracture. This was previously called the tripod fracture from its appearance on radiographs. These are fractures which happen from an impact to the malar eminence, and they fracture or cause diastasis through all four sutures which are on the zygoma. So these fractures can be non-displaced, but when they are displaced can be either angulated or pulled down by the masseter muscle, and this can change the orbital volume, resulting in either exophthalmos or inophthalmos. So this is an example of a ZMC fracture. You see the fractures through all sutures of the zygoma, and on the 3D image on the right, you see that the zygoma is actually inferiorly displaced, which has resulted in an increase in the orbital volume, which will result in inophthalmos. Next is the naso-orbital ethmoid complex fracture, or NOE fracture. This is caused by a posteriorly oriented high-impact force to the nasal region, which causes comminuted fractures of the nasal bones, septum, and ethmoid bones. You can think of this as like the ethmoids being an empty aluminum can, and you stepping on that aluminum can. It causes this telescoping fracture, which decreases the AP dimension of the ethmoids and then splays them out. And so this typically results in exophthalmos and telecanthus, both from the fracture fragments and injury to the medial canthal tendons. It can cause CSF rhinorrhea because of fractures through the anterior skull base. And then lastly, it can cause lacrimal apparatus insult because it's fractures through the nasolacrimal canals and lacrimal fossa. So Markowitz and Manson came up with this classification for NOE fractures based on the necessity to repair the medial canthal tendon. So they described this central fragment, which is the inferior two-thirds of the medial orbital rim, and the attachment of the medial canthal tendon along the anterior lacrimal crest, so that anterior wall of the lacrimal fossa where the lacrimal sac sits. So the three types are basically that the type 1 is where that central fragment is not fragmented at all or comminuted. And so these are typically with an intact medial canthal tendon. Next is when this central fragment is comminuted, but the canthal tendon is still connected to a large fracture fragment. And then last is when there's severe comminution, there's typically a disrupted medial canthal tendon. This takes longer to repair. And so our job, we can look at an NOE fracture and then describe the comminution, especially the comminution involving the lacrimal fossa, and that can help the surgeons know that beforehand they need to look for medial canthal tendon injury, and they may need increased OR time to fix it. And so these are examples of a type 1 on the left side and a type 2 on the right side with mild comminution, but no real heavy comminution involving that lacrimal fossa. Next, I'll talk about the orbital blowout fracture, which is a fracture that happens when you get a blow to either the globe or the orbital rim, and that increased pressure will result in buckling and failure of typically either the medial or inferior orbital wall. And these fracture fragments get displaced away from the orbit. That's why they're called the blowout fracture. Classic orbital blowout fractures do not involve the orbital rim. So if you have an orbital blowout fracture that does involve the orbital rim, it's paramount to discuss that because they need to place a rigid plate and screw fixation on the orbital rim before placing mesh to treat these fractures. There's some common complications. You can get extraocular muscle entrapment, which is a clinical diagnosis. There's very rare situations where we can say for certainty that there's an entrapped muscle. Typically, they give you exophthalmos early from hemorrhage or air, like in this case. And then later on, we'll give you inophthalmos because of the increased orbital volume. And finally, if you have an orbital floor fracture, it can involve the infraorbital canal and result in a cranial nerve V2 territory sensory defect. So this is a case of an old orbital floor blowout fracture on the right, and you can see that the right globe is falling down into the orbit, so you have inophthalmos. And on that coronal image, you see a rounding of the inferior rectus muscle belly with a little bit of linear soft tissue along its inferior margin. And this is a sign that can be associated with entrapment. And so you should describe this and have the clinicians look for that. The trapdoor fracture is a specific type of blowout fracture which does result in entrapment. This is from the literature, and you can see what happens is in these fractures you get a displacement of the fracture away from the orbit with herniation of some of the intraorbital contents through the fracture defect, but then that fracture fragment becomes reopposed like a trapdoor on a stage. And in this case, you can see the inferior rectus herniated inferior to the orbital floor in the maxillary sinus, and so that entraps the inferior rectus. And another interesting thing that can happen in these cases is something called the oculocardiac reflex, where a stretching of the extraocular muscle can cause a parasympathetic reaction, which results in bradycardia and even asystole. And so these are very important to catch and to tell the clinicians. Superior orbital wall fractures are typically different than the medial and inferior orbital fractures. They can often be a blow-in fracture where the fracture fragments get displaced towards the orbit. Since the superior orbital wall forms a partition between the anterior cranial fossa and the orbit, fixing these fractures necessitate an intracranial approach. And finally, since most of these are blow-in fractures, it's typically from a downward force applied by the brain, and so these patients typically have brain contusions. This was a case of a superior orbital wall blowout fracture that I had, where a patient was trying to put a pole into the ground, and the pole jumped back up and hit him in the orbit. So you can get a blowout fracture, but it is rare. Next, the orbital apex fracture. So if you have any fractures which extend through the central skull base, you should look for fractures that involve the optic nerve canal and the superior orbital fissure, because these can result in secondary compromise of cranial nerves or the optic nerve. And so especially since these patients are probably comatose due to polytrauma, we need to alert the clinicians of the possibility of traumatic optic neuropathy so that they can check pupillary responses. Next are zygomatic arch fractures. Since the zygomatic arch is a ring-like structure, these typically fracture in multiple places, and since they're often caused by a lateral to medialized force, they can be displaced medially, and the fracture fragments can impinge upon the temporalis muscle or the coronoid process of the mandible and result in trismus. And in this case, you see it's comminuted and medially displaced, and on the soft tissue window, you have edema adjacent to the fracture, and it's impinging upon the temporalis muscle. Next is the posterolateral maxillary sinus wall fracture. These are kind of like a blow-in fracture from a blow to the masticator space. And what happens is the posterolateral maxillary sinus wall fractures fragments get displaced into the maxillary sinus, and then you can have herniation of retroatrial fat, like in this case. This isn't just a mucus retention cyst. These fractures can be associated with zygomatic arch and mandibular fractures given where the trauma occurs. Next, the mandible. The mandible is a U-shaped structure, and like the zygomatic arch, it's kind of considered a ring, and so it often fractures in two places. You can subdivide the mandible into the parasymphyseal region, body, angle, ramus, condyle, and coronoid process to kind of help describe where the fracture fragments are occurring. This is a common distribution for maxillary or mandibular fracture, where you have a posterior body or angle fracture and then a contralateral parasymphyseal fracture. And it's important to find these fractures because they want to place these patients in maxillomandibular fixation and fix the fractures early on, because the mandible gets so much force during mastication, it can cause these fractures to become non-united. This is another pattern that's fairly common, where if you have a fracture through the condylar neck, the fracture component, including the condylar head, will get displaced anteriorly, medially, and inferiorly by forces directed from the muscles of mastication. TMJ dislocations. So as you can see in this case, we can see the right mandibular condyle seated appropriately in the glenoid fossa of the temporomandibular joint, but then you don't even see the mandibular condyle on the other side because it's been inferiorly and anteriorly translated. And on this 3D reconstruction, you can see the rightward shift of the mandible with respect to the maxilla and the malocclusion caused by that. And this is the same patient looking at the right and left sides. The right side is seated nicely in the glenoid fossa of the TMJ, whereas the left has been anteriorly translated onto the articular eminence. And this patient couldn't open her jaw because that articular disc, which should be sliding with the mandibular condyle, gets stuck behind it and doesn't allow the mandible to go back to its normal positioning. So finally, I'll talk a little bit about some of the newer innovations that the surgeons are using for fixation of facial fractures, and one is intraoperative CT. And this allows them to immediately evaluate their fixation, so they can look where they've placed their plate and screws or mesh, in this case from an orbital blowout fracture, and it allows them to revise it if necessary prior to closing, and so they don't have to come back to do it on a second OR visit. Virtual surgical navigation and planning. This is very useful in patients with the unilateral fractures where they can plan the surgery and how much they need to move some of the facial bones around by using the normal side as a comparison and an overlay. And then you can also use stereotactic information from the CT, kind of like a GPS system, to use a probe to see where you are on the patient's real anatomy during surgery. And finally is 3D printing. This is becoming more widely available, and there's multiple uses for it. You can use it for patient education or resident education. You can make specific patient implants that are perfect matches for the patient anatomy, like in this case, a mesh for an orbital floor fracture. And this was given to me by Dr. Quigley. He makes 3D printing models, and Alas, poor Yorick had a couple mandibular fractures. So in conclusion, CT is the first-line imaging study to assess facial trauma because it can characterize all these different complex facial traumas, and you can see most of the soft tissue injuries that are associated with them. Obviously, some of these newer innovations like intraoperative CT, virtual planning, and 3D printing are becoming more and more available. And so it's up to us to step to the forefront and help the surgeons with this. Thank you for your attention.